Today, we present a comprehensive lecture on traumatic brain injury. We have tried to cover all aspects of the topic. This should be helpful for doctors who are preparing for NEET exam and for all medical personnel who are involved in the management of head injury. Incidents of road traffic accident related head injuries is rising in India. This bucks the global trend where actually the incidence per vehicle on the roads is decreasing. So one factor we have to remember, bad road safety measures and poor protection for motorists, pedestrians, poor conformance with helmet regulations. The second factor is that among the head injuries, the mortality rate in India is higher. So this reflects on poor pre-hospital care, suboptimal evacuation protocols, poor coordination between hospitals, between ambulances and tertiary care centers, and also probably poor management even after the patient reaches the hospital. An analysis of statistics. Let us go on to the mode and the mechanism by which the brain is getting injured. The mode of accident, head injuries. Road traffic accidents are very common. The other causes include falls from heights in younger people and falls even at the same level at the extremes of age. Small children and older people, because of loss of balance, tend to suffer head injuries by falls. Sports can result in acute injuries. Boxing is notorious for it, and boxing produces another condition. Even footballers who keep heading the ball can suffer from what is known as chronic traumatic encephalopathy, also known as punch drunk syndrome. Assault by blunt objects, by sharp objects, or by projectiles. And these projectiles include bullets. It can happen in war. More and more, it is happening in peacetime terror attacks. In war, you have head injuries resulting from bullets. You can have shrapnel from bombers. And also, there is a condition where nothing hits the head, but the blast wave itself produces head injury. What is the mechanism by which the brain is injured when the head is suffering from an injury? One is impact. The surface of the brain suffers a contusion, suffers a bruise, suffers bleed because of impact. Impact can produce fractures, it can produce surface bleeds, and it can produce contusions. The second mechanism is inertia. Inertia occurs because of differential movement between different parts of the brain. The gray matter is denser than white matter. Some parts of the brain are more tethered than other parts. So acceleration, deceleration forces produce injury. Here it is no longer surface injuries, but it is within the depth of the brain because white matter fibers are getting stretched. The third mechanism of injury is because of penetration. Penetration can be by a blunt object, sharp objects, or by projectiles. Some other mechanisms are important to recognize. Hypoxia, a head injured patient has probably an impact injury associated with an inertial injury. There is a loss of consciousness. He has vomited. His airway is not clear, and he suffers from a hypoxic insult immediately. This is a primary hypoxic insult. Hypoxic injuries are often not really recognized, and you wonder why, with this kind of a injury and this kind of a picture, the person's neurological status is poor. Blast forces, as we already said, can injure the brain. Cavitational effects injure the brain in high velocity bullet injuries. The bullet passes through a small trajectory, but around the trajectory, there's an area of cavitation. This is because of a transmission of kinetic energy laterally. Another mechanism which we mentioned is contamination. In any open injury or a head injury which affects the sinuses, you can have contamination of the brain, resulting in infections. Getting to the anatomy of the injury, what are the structures which are injured in a head injury? The outermost layer is a scalp. Scalp can be avulsed or lacerated. When there is a scalp laceration, it is important to stress upon galea closure because a large scalp laceration sutured without galea closure can result in a subcutaneous hematoma formation. Once you close the galea, the chance of that becomes much less. Going to the skull, you can have convexity fractures or skull base fractures. Once you see a convexity fracture on an X-ray or a CT or clinically, the first thing you wonder is it simple or is it depressed? Sometimes just the fact that the galea is split under intact skin might give us an impression of a depressed fracture. This will be corroborated or disproved on a CT scan. If a person has a depressed fracture, then you want to know, is it closed? That is the skin over it intact, or is the skin also split? In which case there is a risk of contamination. Sometimes open fractures are defined as when the dura is torn or not torn. Both are important, but if the dura is torn and the skin is torn, it becomes an open fracture with a risk of contamination. Another factor which you should always look for is, does the skull fracture cross a vascular marking? Important in the temporal region, middle meningeal marking. If it goes across, you can have a large extradural hematoma, which is life-threatening, developing very rapidly. Again, vascular markings include the sagittal sinus or the torcular or the transverse sinus. Skull base fractures, usually the most obvious thing is bleeding from the ear, bleeding from the nose, or bleeding from the mouth. If you look for it and you are aware of it, you will often find that there is blood mixed with CSF, which appears as a double ring when you take the blood on a filter paper or a handkerchief. It's called the halo sign. CSF rhinorrhea, or even just a plain ENT bleed, tells us that we should tell the patient, do not blow the nose, because otherwise pneumocephalus can increase and contamination of the brain will increase. Skull base fractures are often associated with cranial nerve palsy. Olfactory, first cranial nerve, very often affected even without a skull base fracture. Patients manifest only with the loss of flavor of food later. Optic nerve injuries, look for it. Pupillary asymmetry, not explained by a tentorial herniation, might show that there is an optic nerve. Look for consensual light reflex. The pupil will constrict when you shine a light in the opposite eye. All cranial nerves can be involved. Sometimes the patient can just present with hoarseness of voice. And then when you start orals, you'll find that they are aspirating and they have nasal regurgitation. Some of the lower cranial nerves may be involved. Vascular injuries because of skull base fractures are fortunately not very common, but they can be devastating. Carotid artery can be injured. These are very difficult to manage except by endovascular procedures. Some of the well-known signs of skull-base fractures include raccoon eyes or battle sign, which is a bruising over the mastoid region, reflecting a middle cranial fossa fracture. Continuing with the structures which are involved in a head injury, let us look at the meninges. If the dura is intact, there is no meningeal injury. If there is a dural rent, it might be associated with an injury to the venous sinuses. Temporal region, you can have a middle meningeal artery injury even without a dural rent. Vessels are involved producing hematomas. Extradural hematomas can occur with skull fractures. Diploic vessels can result in the production of an extradural hematoma that is outside the dura. Meningeal arteries can be torn, classically middle meningeal artery injury, again extradural hematoma. Venous sinuses can be injured when there is a fracture crossing the midline or a fracture which is crossing the area of the transverse sinus. Here, you will find that there is an EDH, but very often, unless the EDH is producing significant pressure, these are managed conservatively as against a meningeal artery involvement where you have to go in and control the bleeding, because venous sinus bleedings after surgery are sometimes difficult to control. If it is producing a large mass effect, you have to go in being prepared to get sinus hemostasis, which is no small undertaking. On CT, an extradural hematoma has a lenticular, that is a biconvex shape. And usually, whenever there is a small extradural hematoma which is being managed conservatively, we need to repeat a CT scan after about 4 hours to see if it is rapidly increasing. Subdural hematomas, that is under the dura, outside the brain, can occur because of injury to the surface vessels, which might be arteries, small arteries, or it might be because of rupture of the bridging veins which are draining from the surface of the brain to the sinuses might get avulsed. On CT, a subdural hematoma has the appearance of a crescent. It's called a crescentic shape of a subdural hematoma, as opposed to the lenticular shape of a extradural hematoma. Intracerebral hematomas usually occur because of inertial stress. One of the vessels within the brain parenchyma gives way. You have a spheroidal shaped hematoma forming inside the brain substance. There is also a condition called delayed intracerebral hematomas, a small bleed which has occurred inside the brain parenchyma, closed off with a clot dissolving substances from the local brain and the response result in an opening of the clot and a delayed formation of an intracerebral hematoma. So patients with delayed neurological manifestations after a not so major injury might have a delayed traumatic intracerebral hematoma. Continuing with an anatomical description of the structures which are damaged in a traumatic brain injury, we have neurons and axons. Neuronal disruption can occur because of direct injury. That is the primary injury. Neuronal injury also occurs because of other insults. Hypoxic injury. The neurons require a higher oxygen delivery than the axons. So hypoxic injury can worsen neuronal injury. Metabolic factors which occur immediately after head injury, which we will discuss, can result in a neuronal insult. And neurological injury can be because of seizures. Repeated seizure activity actually damages neurons because of the increased metabolic response, that is one, resulting in a metabolic oxygen delivery mismatch, and also direct injury to the internal structure of the neuron by seizure activity. Axons are damaged mostly by stretch. But the severity of axonal injury varies from the relatively trivial concussions, what we call. There are axonal conduction failures in the brainstem occur for a period and then there is a recovery of conduction. Cytoskeletal injuries occur when the axon seems anatomically intact, but the microskeleton or the support systems in the axon are disrupted. This results sometimes in a beading of the axon, which is known as an axonal varicosity. And then you have axonal disruptions, which can result on histopathology which can show up as an axonal retraction bulb, not seen on imaging usually, but it can be seen on electron microscopy. Axon injuries have also been classified depending upon where they are located. Grade 1 axonal injuries are at the gray-white junction. Grade 2 are at the corpus callosum, rather just adjacent to the corpus callosum. And grade 3 axonal injuries occur in the brainstem. Remember that the radiological markers of an axonal injury are because of microvascular ruptures. So in fact, you can have a grade 3 axonal injury within the brainstem, which is associated with a small brainstem hematoma. These are to be differentiated from the durate hemorrhages, which often occur with herniation syndromes, which have got a very poor prognosis. A small brainstem hematoma sometimes just manifests with internuclear ophthalmoplegia. There is a failure, a difficulty or an abnormality detected on eye movement examination. Diffuse axonal injury is a term which suggests that there is axonal injury all over the brain. These patients may not have very obvious neurological findings radiological findings on CT. However, neurologically, they are very impaired. So most head injury patients have a combination of both impact and inertial injuries. And the inertial injury component, which affects the axons, may not be radiologically apparent. Axonal injuries, again, do better when the myelin sheath is intact. This is one of the reasons why very young children who suffer an inertial brain injury sometimes have very poor outcomes. That is because they don't have a myelin sheath to protect axonal integrity and help axonal regeneration, not fully proven. Therapeutic modalities available for treatment of the primary injuries is quite limited. Much of the management of traumatic brain injury is for preventing or treating the secondary injuries. Secondary injuries can occur because of increased intracranial pressure. Why does increased intracranial pressure occur? It is a response to injury, inflammatory response to injury, swelling of the brain. We'll come to the different causes of increased intracranial pressure. The Montefiore doctrine is that the skull is a fixed volume compartment with brain occupying about 1,200, more than that, 150 ml of CSF and 150 ml of flowing blood. So when the volume of contents inside the fixed cranial cavity increases, the pressure increases. How does that affect the brain? Because one is that the cerebral perfusion gets affected. Mean arterial pressure, that is diastolic into 2 plus systolic, the whole divided by 3, minus intracranial pressure is cerebral perfusion pressure. So when intracranial pressure increases, cerebral perfusion gets impaired. It's a little more complex than that. We'll come to that later. What are the causes of increased intracranial pressure? There is cerebral edema, Kaller, Dollar, Ruber tumor, swelling because of an injury. This edema can be cellular. The neurons and the glial cells swell. Why does the cellular swelling occur? This is because of a failure of the membrane pumps. The sodium channels, the aquaporin channels, they don't work because of a metabolic failure. The second kind of edema is interstitial edema. Here, there is a breakdown of the blood-brain barrier. Normally, the brain capillaries have tight interendothelial junctions, supported by astroglial foot processes. A failure of the metabolism in glial cells results in a retraction of foot processes. Endothelial gaps open up, passive effusion of fluid into the interstitial space. The second cause of increased intracranial pressure is a hematoma. This hematoma might be extradural, as we already said. It can be subdural, or it might be intracerebral. Remember, a hematoma is a space-occupying mass within the cranial cavity, resulting in an increase in intracranial pressure. Hydrocephalus occurs after a head injury because of a blockage. This blockage can be within the ventricular system, resulting in an obstructive hydrocephalus, or it can be an absorption failure because the blood floating in the subarachnoid space can result in an occlusion or a decreased absorption within the arachnoid granulations, which are supposed to draw back the CSF into the venous circulation. Pneumocephalus, when it becomes a tension pneumocephalus, can result in increased intracranial pressure. The correlation between increased intracranial pressure and neurological deficits is complex. The simplest thing to understand is that mean arterial pressure minus intracranial pressure is the cerebral perfusion pressure, and increase in intracranial pressure results in a decrease in cerebral perfusion. There is a cerebral auto-regulatory zone, normally between 50 to 150 millimeters of mercury. The brain has got a capacity to auto-regulate. How does it do that? By contraction of the small arterial muscles. This 50 to 150 millimeters of mercury is set at a higher range in hypertensives, for example. Now, impaired auto-regulation is a feature of traumatic brain injury. So even if you have an adequate cerebral perfusion pressures, somewhere between 50 to 150, you can still have anoxia because auto-regulation is impaired. There is passive vascular congestion, which is an auto-regulatory failure which occurs with head injury. Actually, a post-decompressive craniectomy patient seems to have a swollen brain. And subsidence of this swelling is not just recovery of edema, it is also a manifestation of return of cerebrovascular reactivity. So, cerebrovascular reactivity or cerebrovascular regulatory capacity restoration manifests as improved neurological function. So increased ICP coupled with a cerebral autoregulatory failure results in brain hypoxia. This is the reason why you had this DECRA study in New Zealand, which randomized patients with increased ICP without mass lesions, which obviously would require surgical evacuation, into two groups, best medical management and bilateral decompressive craniectomy when the ICP was not controlled, and for them the control was 20 millimeters of mercury by medical means. They found that actually doing bilateral decompressive craniectomies, which would control the ICP, did not really improve neurological outcomes. The reason is that head injury dysfunction, neurological dysfunction, is not just because of increased ICP, but because of multiple factors. One of the most important of which is probably a failure of cerebrovascular reactivity. Secondary injury, we said increased intracranial pressure is one of the major causes. Now, another cause of secondary injury is a herniation syndrome or a brain shift. Why do you call it a herniation? Because the intracranial chamber is actually compartmentalized by dural folds. You have the vertical midline partition called the falx cerebri, and you have a horizontal fold between the occipital and temporal lobes and the posterior fossa. So because of these partitions, the brain can herniate from one chamber or one compartment to the other. So under the fox, you can have a herniation which is called a subfalcine herniation. Through the opening in the tentorium, you can have a herniation called a transtentorial herniation. And you also have herniations through the foramen magnum, which is where the medulla continues through the bony opening as the spinal cord. How does herniation produce neurological syndromes? Vessels can get occluded. Cranial nerves can get pressed upon or distorted. And some of the tracts can get compressed or distorted. There can also be CSF or cerebrospinal fluid channel blocks. Let us start off with subfalcine herniation, commonly underdiagnosed. Whenever you say a patient has got a midline shift, actually you can assume that there is a certain degree of subfalcine herniation. The part of the brain that herniates in a subfalcine herniation is the cingulate gyrus. Herniations, subfalcine, can affect the anterior cerebral artery. The anterior cerebral artery arches over the corpus callosum as it supplies the medial strip of the cerebral hemispheres. So anterior cerebral artery occlusion on one side will result in contralateral monoparesis. That is, the leg area is in the superomedial aspect of the cerebral cortex, of the motor cortex. So anterior cerebral artery occlusion can result in contralateral monoparesis involving the opposite leg. A CSF path can get blocked. The CSF in the lateral ventricle on the ipsilateral side, where there is increased pressure, has already been squeezed or compressed. When there is herniation, when there is a pressure across, you can have a blockage of the foramen of Monro on the opposite side. That means the contralateral lateral ventricle cannot drain into the third ventricle. So this is often seen on CT. Whenever you find that there is a mass effect, when they see that there's a midline shift, look at the opposite lateral ventricle. Is it distended? It is because of a blockage of the foramen of Monro. Transtentorial lateral herniations produce some certain classical syndromes, which is the part of the brain that herniates the medialmost part of the temporal lobe. That is the uncus of the temporal lobe. When the uncus herniates down, it can press upon the third nerve, the oculomotor nerve. Supplies all the muscles of eye movement except for LR6 and SO4. Lateral rectus is supplied by the sixth, the superior oblique is supplied by the fourth. Now, the third nerve also carries on its dorsolateral aspect parasympathetic pupillary constrictor fibers, which are coming from the Edinger-Westphal nucleus. So, when there is an uncal herniation, there is pressure upon the third nerve, and initially it does not produce oculomotor palsy. It produces parasympathetic palsy. Parasympathetics constrict the pupil, sympathetics dilate the pupil. Sympathetics are not coming in that route, they are coming along with the vessels. So parasympathetic palsy results in an unopposed sympathetic action and a widely dilated ipsilateral pupil. Midbrain passes through the tentorial hiatus. The corticospinal tract on the same side gets compressed, which will result in contralateral hemiparesis. Sometimes the whole midbrain unit is shifted across, which results in the tentorium on the other side pressing on the opposite midbrain press, which can produce an ipsilateral middle, hemiparesis. One of the vessels which can get occluded is the part of the posterior circulation that supplies the occipital lobe. Well, how is the posterior circulation formed? The two vertebral arteries unite soon after the foramen magnum to form the basilar artery after giving off the pica, posterior inferior cerebellar arteries. Then you have the ica, which is coming out. Then you have the superior cerebellar arteries. And then the basilar artery divides into two branches as it comes over the tentorium. The two posterior cerebral arteries. This posterior cerebral artery supplies the thalamus, and also it supplies the occipital lobe. So the PCA can get compressed, resulting in occipital infarction. Ipsilateral occipital infarction will result in a contralateral loss of field. The opposite visual field can get affected. Continuing with the herniation syndromes, you can have a foramen magnum herniation. The pressure inside the posterior fossa has also increased, resulting in the cerebellar tonsils descending through the opening, through the foramen magnum, along with the spinal cord. Now, this occurs in Arnold-Chiari malformations also. But an acute cerebellar tonsillar descent presses not only upon the cord but also on the medulla, because of increased intracranial pressure, the medulla has also descended. So, in a foramen magnum herniation due to increased ICP, you will have compression on the medulla, and this results in cardiac and respiratory failure. Other subtle herniations, you can have a reverse herniation transtentorially, or you can a central herniation where there is a midbrain descent. Here, the findings are more subtle. You can have Cheyne-Stokes breathing, that is, periods of hyperpnea followed by an apneic pause. You can have gaze paralysis, especially up gaze, and the pupils may remain constricted. So much for herniation syndromes. Now let us look at seizures. Why do post-traumatic seizures occur? This is not fully proven, but immediate seizures are because of the excitotoxic surge. Early seizures occur because there are inhibitory interneurons which prevent lateral spread of impulses because of a dysfunction of inhibitory interneurons. Delayed seizures have a worse prognosis because these have resulted because the brain is trying to repair itself. It is forming new synapses, and neosynaptogenesis may result in aberrant synapse formation and result in a post-traumatic epilepsy syndrome. Another cause of neurological deterioration secondarily after head injury is neuroinflammation. Neuroinflammation starts immediately after injury. What is sad is that the effects can last for years. Patients who initially were better can stop improving or maybe even deteriorate. How is the inflammation mediated? There's activation of the glia by damage-associated molecular patterns, mitochondrial disruption components, some of the blood components which seep across the blood-brain barrier. Cytokines are both pro-inflammatory and anti-inflammatory. Even glial cells, which are activated microglia and astrocytes, contribute to the inflammatory response. Microglia are the most abundant mononuclear phagocytes, which constitute almost 10% of the total CNS cells. But there are two types. M1 microglia are pro-inflammatory and promotes apoptosis, that is ongoing self-programmed cell death. And M2 are anti-inflammatory. It actually promotes healing, neurogenesis. Other factors contributing to secondary injury include glucose metabolism. The cells are unable to utilize glucose after a head injury. Impaired glucose utilization, actually glucose becomes toxic. There is also glutamate release. It can produce seizures. It can also produce neurological damage. Oxidative stress is a major cause of inflammatory damage to the neurons. Electrolyte disturbances occur after a head injury, very common. One is you have a SIADH or syndrome of inappropriate ADH secretion. That is excessive ADH, antidiuretic hormone, is produced. More water is retained by the kidney, and there is a dilutional hyponatremia. The second is there is something called cerebral salt wasting, increased ACTH, and the secretion of something called atrial natriuretic peptide, result in an increased loss of salt, again resulting in a loss of both fluid and salt. But because salt is lost excessively, you have hyponatremia without an increase in volume. The third is diabetes insipidus. Here the sodium level goes up because of a failure of ADH secretion. There is excessive excretion of pure water and sodium level rises. Diabetes insipidus especially may be associated with a poor prognosis. If the sodium level is going above 170, sometimes the patients have extremely poor outcomes. What are the clinical features of a head injury? You have loss of consciousness. Why do patients lose consciousness after head injury? You can operate on the cerebral cortex in an awake patient and the patient remains awake. But a head injury results in loss of consciousness very often. Why does it happen? It is because of the inertial injury component. And which part is involved? The brainstem. The brainstem helps keep you awake. So stretch of brainstem fibers results in a failure of contraction transiently, which can result in a loss of consciousness, even in a minor head injury. Vomiting. Vomiting occurs after head injury. Why does it occur? The cerebrospinal fluid gets displaced. There's a pulse of fluid which impinges upon the floor of the fourth ventricle, resulting in vomiting. Seizures we have already talked about. Immediate seizures because of excitotoxic surge, early seizures because of inhibitory neuron dysfunction, and delayed seizures because of aberrant neurosynaptogenesis. General features of increased intracranial pressure, we all know. It's called the Murphy's triad. You have hypertension. Hypertension occurs because the compensatory reflex to counter the ICP rise and maintain CPP. Bradycardia is secondary, so the Mary's reflex, where because of hypertension, heart rate becomes less. And you have respiratory irregularities, probably mediated by the brainstem. Remember that bradycardia and hypertension are the features, cardinal features of a head injury. It is not tachycardia, tachypnea, hypotension, oliguria, cold clammy extremities, and obtunded sensorium, which can be present in hemorrhagic shock. Do not ever mistake hemorrhagic shock as a head injury. If the patient is having tachycardia and hypertension, look for bleeding, occult internal bleeding, hemoperitoneum, hemothorax, fractures of major bones. Exclude that before you think that it might be one of the rarer head injury syndromes involving the brainstem, which is resulting in hypertension. Continuing with the clinical profile, we have already discussed the clinical features of herniation. Subfalcine herniation results in contralateral monoparesis, ACA block, and contralateral lateral ventricular dilatation, Foramen-Monro occlusion. Lateral transtectorial, this uncal herniation, results in ipsilateral pupillary dilatation, contralateral hemiparesis, and contralateral loss of visual field. Foramen magnum herniations result in cardiorespiratory instability. What are the features of skull base fractures? You can have CS of rhinorrhea, you can have the battle sign, mastoid bruising, or raccoon eyes. When we talk about loss of consciousness, we should also be able to grade consciousness, because when you want to transmit information from one person to the other, ambulance crew wants to tell the hospital how serious the person is. You need to be able to quantify the loss of consciousness. And for that, a scale has been devised called the Glasgow Coma Scale. We are all aware of it. It was devised by Janet and Teasdale at the Glasgow Hospital, hence the name Glasgow Coma Scale. Also known as EMV scale, eye motor verbal response scale. Remember, eye is eye opening. Eyes open spontaneously, 4 points. Eyes open to call, 3 points. Eyes open to pain, 2 points. And eyes remain shut, 1 point. Remember, a person who's got facial injuries might have swollen eyes which do not open. That does not make it E1, but you generally say that eyes are swollen shut. Verbal response, normal speech, a person who can speak coherently, 5 points. Confused speech, you give them 4. Single words, you give them 3. Groans and moans, give them 2. And no phonation, only breathing, noisy breathing you might hear, that is 1. Remember, verbal response you cannot quantify when a person is either intubated, has got a tracheostomy tube, or also in patients who are dysphasic because of an injury to the speech areas. Now, so there you write V dysphasic or VET, that is with endotracheal tube, or V tracheostomy. Motor response, the most important part of GCS, a person who obeys commands is M6. If you can localize pain, you pinch him on the ear and he brings his hand and pushes your hand away, it is M5. Flexor withdrawal, you pinch his hand or you try to start an IV, he withdraws the hand, that is M4. Abnormal flexion is M3. Abnormal extension is M2. And no movement is M1. Remember that patients who are paralyzed cannot move. So a person with quadriplegia, limb movements might be absent. Does not make him M1. You ask him to put out his tongue, he will put out his tongue. Or you ask him to blink his eyes, he'll be able to do that. That happens often in locked-in syndromes, where you have a pontine myelinolysis. Patient, the only movement he can make is open and close his eyes. He can probably talk in Morse if he knows Morse code. What are the investigations you will do in a patient who presents to the emergency with a head injury? Plain X-rays have got a limited role now, but they still have a role. When you don't want to do a CT because the indications are not so much, or it's a small child where you don't want to expose them to the radiation of the CT, or if there's not much of a chest injury, but you just want to see that the lung fields are clear, you might go for X-rays. Actually, an X-ray skull is very informative because it will show you when you depress fractures. It will show you the total outline of the fracture, which is sometimes difficult to ascertain on a CT film unless you do a reconstruction. Cervical spine is important to assess, but usually it comes in the trauma series. Cervical spine lateral view gives some information. Actually, mostly it gives you optimal information on cervical stability. Chest X-rays will show you if there is a consolidation or a collapse or a hemopneumothorax, but usually now a CT thorax will give you much more information. CT brain is the investigation of choice in traumatic brain injury. It shows you fractures, it shows you pneumocephalus, it can show you bleeds, EDH, lenticular shaped, just adjacent to the bone. SDH, crescentic. Usually SDHs are also associated with significant brain edema. So midline shift is more than what you would expect from the thickness of the SDH. ICH, spheroidal shaped. Contusions have got a salt and pepper appearance. It's a surface bruising which has resulted in bleeding into the brain substance. CT gives you a salt and pepper appearance. Contusions tend to increase over time, especially bifrontal contusions have got a risk of delayed. That is up to maybe on day 5, they can have a seizure and suddenly go. Because midline shift also does not become obvious because of the bifrontal nature of the contusion. Diffuse axonal injury may manifest as micro bleeds. Small bleeds can be seen, but sometimes you can have axonal injuries also without micro bleeds, which might not even be picked up on MRI. Subarachnoid hemorrhage, traumatic, is usually a thin film on the convexity. Rarely you can have patients who can have basilar subarachnoid hemorrhage or subarachnoid hemorrhage into the sylvian fissure. In these patients, it is important, even if they had a road traffic accident, it is probably important to get a CT angio done. Was the road traffic accident caused because the patient lost consciousness because of an aneurysmal bleed? Hydrocephalus can be seen on CT. Herniations can be assumed on CT. In a univentricular dilatation, you say there is subcallsign herniation. Also, a midline shift becomes obvious. Brainstem shift also can become obvious. The midbrain unit seems to be shifted to the opposite side. Direct evidence, you can see the descending uncus. encroaching upon the perimesencephalic cisterns. Infarcts are well seen. Infarcts in head injuries might be watershed infarcts because of increased intracranial pressure between the MCA territory and the PCA territory. You might find an infarct, common sight. Edema, you find loss of gray-white differentiation. And a hypoxic brain is often apparent to a person who has been seeing a lot of CT scans. Look at the brain and you realize it is dark. And then you have something called the white cerebellar sign. Compared to the cerebellum, the brain is dark. So you say probably there is a very major hypoxic insult. MRI brain has got a limited role in traumatic brain injury. Firstly, because blood is very easily seen on a CT scan. And most of the actionable information in a traumatic brain injury is seen on a CT. MRI involves shifting the patient into the console, not being able to monitor unless you have all the non-magnetic monitoring devices, lack of access to the patient while the imaging is in progress. However, it is the investigation of choice when there is a MRI is, of course, the investigation of choice in a spinal cord injury. MRI is also important in the assessment of optic nerve injuries. When you find there is an optic nerve injury, you can get an MRI, look at the optic nerves, and make a decision on whether surgical decompression, which is usually done by the endonasal endoscopic route nowadays, is warranted or not. You can have a better visualization of the brainstem with an MRI. And it is also important in diagnosis of DAI, and not to mention any vascular injuries resulting in an infarction will be better seen, better delineated on MR imaging. Transcranial Doppler has got more of a role in aneurysmal subarachnoid hemorrhage with a limited scope in TBI, traumatic brain injury. It basically is used to measure the blood flow velocity, which is increased when there is vasospasm. Near-infrared spectroscopy is being evolved. However, the localization is not very good as to which area is hypoxic. And here, correlation, CT, NIRS, co-registration can help in better localization of hypoxic regions. ICP monitoring, intracranial pressure monitoring, is part of the investigative invasive armamentarium of head injury management. You can monitor intracranial pressure by using an intraventricular catheter. This is the most accurate, and you have the additional privilege of being able to drain out some CSF in case there is an ICP crisis. Parenchymal catheters are often used. These parenchymal catheters are the easiest to place, and they can be sometimes combined with multi-modality monitoring. That is, along with ICP, you can also measure brain tissue oxygenation level, and you can also measure the lactate pyruvate ratios. Multi-modality monitoring has been shown in some studies to improve neurological outcomes in intensive care head injury management. Subdural balls and extradural sensors are rarely used because they are not as sensitive. Neurological monitoring remains paramount. That is most important. Glasgow Coma Scale. Any deterioration in Glasgow Coma Scale, get electrolytes done, get the sugar done, look for any evidence of seizure, and then repeat a CT. Pupils, pupillary asymmetry evolving, definitely sign of herniation. Initially, pupils normal, later pupil dilating, has to be another herniation. Motor response is the person's paralysis worsening. Radiology serial CT scans are often done to see how a hematoma is evolving. Even if the hematoma does not increase in size, there might be perihematoma edema which will increase, which might result in a crisis. X-ray test is often done. Remember that most head injury patients who lose consciousness aspirate some saliva at least. This saliva or any gastric contents can damage the alveolar membrane. Now, this damaged alveolar membrane is like a burn surface. Infections colonize, and you can get chest infections. So, by day 3, many of these patients of serious brain injury might develop aspiration related pneumonias. Arterial blood gases are used for daily monitoring. You want to optimize the PCO2 and the PO2 to maintain optimal cerebral circulation. PCO2 is high, vasodilatation occurs, ICP goes up. PCO2 is optimally kept around 35. Very low PCO2, vasoconstriction might result in infarcts. Routine blood work is also done. How do you manage a head injury patient? Remember, the principles of casualty management, airway, breathing, and circulation applies here also, with special emphasis on the nervous system. Try to maintain the airway. You have to maintain the airway while the patient is being evacuated. You can do maneuvers like a jaw lift. Hyperextension of the neck is not recommended if the patient's neck has not been cleared by radiology. That is, you haven't even done an X-ray. If the patient is vomiting, clear out the secretions. Roll the patient over on the lateral side if he's vomiting. Breathing, if he's not breathing, that means that he either requires ambu bag ventilation or he requires invasive ventilation. So even if the airway is clear, the patient's GCS is very low, breathing might be affected. Circulation, see the pulse. If he is having a feeble pulse, he might be having bleeding somewhere. How do you decide on whether a patient requires intubation or not? There are multiple factors which are involved. The first is a Glasgow Coma score. A GCS of 8 or less than 8, the breathing will be inadequate and the ICP will be better managed by intubation and positive pressure ventilation. Airway maintenance becomes a problem when there are fractures, when there is soft tissue involvement, when there is bleeding into the oropharynx. In these cases, you might require to intubate a patient to protect the airway. And sometimes a patient who is not so bad, but not fully conscious, who is planned for transfer by air from a remote area, might be better intubated because it will avoid a crisis en route. If a patient has got seizures, not easily controlled, repeated seizures are happening, then the patient is better intubated because then you can give drugs which can abort the seizures, but which might result in some amount of respiratory depression, which could be critical in a patient who has already got a traumatized brain. What are the IV fluids which are given? Normal saline is conventionally given all over now. Dextrose normal saline has got a role. It's a little more osmotic than a normal saline. However, extra glucose may be toxic to the brain. This is a contentious point. Is there a role of colloids? Colloids are given if there is hypertension. But there is a possibility that an open blood-brain barrier might result in colloid effusion into the extra cellular space of the brain, resulting in an increase of edema later on. Anti-edema measures which are given in head injury include mannitol. Mannitol has got multiple methods of action. Initially, when mannitol goes into the circulation, it draws fluid from the interstitium. So there's an increase in circulating volume and an increase in cerebral blood flow. Then you have fluid being drawn back across the blood-brain barrier by osmotic mechanisms. You have diuresis because of mannitol. Again, blood gets more concentrated, the Donan membrane equilibrium, fluid is drawn back from the extracellular space in the cranial cavity into the vascular channels. Mannitol also improves the rheogenic properties of blood. The cells become more pliant. It has also got an antioxidant role. Hypertonic saline has been given in various studies, concentrations varying from 3% to more than 20%. It has been shown that the incidence of acute tubular necrosis, which occurs with increase in osmolarity of, say, more than 320, which occurs with mannitol, may not occur with hypertonic saline. So a bit easier on the kidney. Hypertonic saline has also got the additional advantages is that it corrects blood pressure because it draws in more fluid, and also hyponatremia, which can occur in a traumatic brain injury, is corrected. Anti-seizure medication is often administered in traumatic brain injury. Usually what you do is you give a loading dose followed by a daily maintenance dose. Now, is there an indication for prophylactic antiepileptic drugs? There have been studies which have shown that prophylactic antiepileptics do not benefit a patient. But these studies have been conducted in very high level intensive care units because the patient is already sedated with drugs like diazepam, which will have an anti-seizure effect. Why would you give prophylactic antiepileptics? When a brain is already edematous and hypoxic, a seizure would aggravate the hypoxia and increase the intracranial pressure. So a prophylactic antiepileptic would probably prevent this crisis from occurring. So immediate and early seizures can be suppressed by antiepileptics. However, remember that anti-seizure medications suppress seizures. They do not prevent epileptogenesis. That is, a neosynaptogenesis that results in post-traumatic injury is not prevented. Is there a role of steroids? The CRASH trial, which was corticosteroid rescue in acute head injury study, was aborted because they found that actually the outcomes were worse in patients who are administered steroids. However, certain subsets might show benefit of steroids, which should be decided by the individual clinician. Optic nerve injury, spinal cord injury, there is definitely a role. The NASA study has shown benefit in spinal cord injury. However, the analysis later on has shown that probably the risk of deterioration, especially in patients who have associated chest injuries and infections or other comorbidities, might be more in a patient who has been administered methylprednisolone. Contentious, but most people would give it in a spinal cord injury if there were no major other confounding factors. Role of tranexamic acid, evidence not fully available, but being used. Vitamin K, again, in certain patients, vitamin K has a role, especially if there's an alcoholic who's come with a head injury, or you suspect that the INR is deranged, vitamin K definitely has a role. What are the surgical options in traumatic brain injury? Decompressive craniectomy is the first thing that comes to mind. What are the aims of a decompressive craniectomy? You want to control intracranial pressure and you want to evacuate hematomas. Controlling intracranial pressure alone might not be a very hard indication, but I would do it, and most neurosurgeons would do it if medical management was not giving positive results. The DECRA study showed that in patients who did not have mass lesions with bilateral increased ICP, even if you did a bilateral decompressive hemicraniectomy, the outcomes were not superior to best medical management. In fact, in some ways, they were inferior. Decompressive craniectomy can be a hemicraniectomy when one hemisphere is swollen. If the frontal lobes are more involved, you can do a bitemporal decompressive hemicraniectomy, leaving, of course, the sagittal sinus intact. Is there a role for limited procedures? One of our colleagues from Nepal has got a very good series where he has done a limited small craniotomy and just done cisternostomy, just done open the cisterns, allow the CSF to drain. It goes against our intuition. However, possibly some of the toxins which are accumulated after injury, where excitotoxic surge or the inflammatory mediators might be drained with the drainage of CSF, which gives you that edge so that you can continue with other medical management. Not recommended, not proven. What are the principles of a decompressive cranectomy? Now, one more thing about limited procedures. you find that some patients, when you do a decompressive craniectomy, in all cases, you'll find the brain is swollen out. Does this excessive brain projection result in a stretch axonopathy, which is worsening the neurological insult? Difficult to prove it, but it is something worth considering. The principles of a decompressive craniectomy involve a wide craniectomy, a dural opening which maximizes the use of the craniectomy, duroplasty, and then how do you preserve the bone? You can either preserve it by refrigeration, which is sometimes difficult, or you can preserve it in the anterior abdominal wall in a subcutaneous pouch. One of the problems in preserving a bone flap in the abdominal wall, is that very often these patients develop bacteremia, if not septicemia, while they are being on ventilator. And this might result in seeding of the bone flap in the abdominal wall, which might result in a cranioplasty infection when you put it back. Cranioplasty can be done by autologous bone, a preserved bone from the anterior abdominal wall, or you can use synthetic analogs. Meshes, titanium contoured implants are available. Head injury involves a wide spectrum of injuries. Recovery from head injury, therefore, is difficult to predict. Most patients who had even a mild or moderate head injury might not have a memory of the event. Even after the memories start coming back, the period of amnesia constricts, but the actual event might never be remembered. There is a seizure risk which is maximal in the early postoperative period, excitotoxic surge, loss of lateral inhibition. The Glasgow Outcome Scale quantifies outcomes into wet, persistent vegetative state, dependent, minimally dependent, and independent existence. Mild traumatic brain injury, is it significant? Even mild traumatic brain injuries have cumulative effects. So there are obviously axonal injuries and a load which can accumulate and which can even result in seizure production at a later stage. What is the pathology of an inertial injury? Pathology of inertial injury, remember, is disconnection. The connections of neurons are lost. So it goes by logic that reconnection might result in restoration of functions. If the axon is not ruptured, you can have a restoration of axonosynaptic connectivity or conductivity. Oligodendrocytes probably help in this restoration. Sometimes you can have delayed awakening from coma states after traumatic brain injury. This usually happens because of neosynaptogenesis. An intact cortical island, which has been deafferentiated, gets reconnected by axonal reconnections, and the patient has a flood of memories which come back. We have seen cases, not very common, but patients who were tracheostomized, sent home on an M2 response, who started having cognitive, almost normal function later on, but who developed motor problems because they already developed ankle contractures and things of that sort. Neuronal plasticity is another entity. Here, areas of intact cortex take over the function of damaged, irreversibly damaged cortex. This plasticity is more pliable or occurs more in the very young. That is the reason why some of the epileptic operations, where you do a hemispherotomy, for example, you do it in a very young age. Neural stem cells, do they have a role in neurological functional recovery? Probably not much of a role, but we know that there are neural stem cells available in the hippocampus, dendrite gyrus of the hippocampus, or in the subependymal zone of the ventricles. These cells can migrate, integrate, and result in some improvement of function. However, to harness that properly is something we have to look forward to in the future. Thank you.